Thank you, Dr. Brenner, Dr. Shons, and Dr. Shen, and Dr. Wang for the robust discussions and providing the insight into the molecular mechanisms and therapies that have a broader impact on cancer and graft-versus-host disease. Our next session is on advancing global psycho-oncology care. The chair of these sessions will be Dr. Jaroslava Salman, Chief and Assistant Clinical Professor, Division of Psychiatry in the Department of Supportive Care Medicine at City of Hope. Dr. Salman obtained her medical degree from the University of PJ Safarik in Slovakia and completed her general psychiatry and psychosomatic medicine fellowship residency at UCLA. Before joining City of Hope in 2014, Dr. Salman was the medical director and assistant professor of psychiatry at the University of Southern California. She received many awards for her exemplary work and contribution, including the Fellow of Academy of Psychosomatic Medicine Award. Welcome, Dr. Salman.
Thank you, Dr. Ogembo. It's my honor and pleasure to introduce our next two speakers. And I'll start with Dr. Xiomara Rocha-Cadman, who I have the privilege of having as my colleague here at City of Hope. Dr. Rocha-Cadman is a psychiatrist and an assistant clinical professor at the Division of Psychiatry under Department of Supportive Care Medicine here at City of Hope. She obtained her medical degree from Universidad Autónoma de Guadalajara in Mexico. Dr. Rocha-Cadman completed her residency in psychiatry at Lincoln Medical and Mental Health Center and Weill Cornell Medical College, and a clinical psychiatry fellowship at Memorial Sloan Kettering Center in New York. She worked as a psychiatrist at Memorial Sloan Kettering Cancer Center for 9 years before joining us here at City of Hope. She was the program director of the Consultation Liaison and Psycho-Oncology Fellowship at Memorial Sloan Kettering Cancer Center before coming to City of Hope. She received a Physician Excellence Award in 2021. As a Department of Supportive Care Medicine member, she provides bedside psychotherapy for patients undergoing a bone marrow transplant and other cancer treatments. She's a proponent of end-of-life care and seeks opportunities to serve the community and collaborates internationally by educating and expanding awareness of early cancer detection, psycho-oncology, and palliative care.
Thank you, Yara. Can you guys hear me well?
We can hear you.
Yes. So I'm trying to share my slides, and it's also my honor to be here today and present for you all a field that is so important to me and I'm very passionate about, which is the field of psycho-oncology. My title is Advancing Global Psycho-Oncology and Psycho-Oncology Care and Practice and Approach of Psycho-Oncology with Latinx Community in Latin America. I will ask for the next slide. Okay. I have no conflicts of interest. Basically, the background would be that I will talk a little bit about the history of psycho-oncology, my work with the Latinx community, and how we advance global psycho-oncology care through national and international collaboration. Next slide. Let me start out with this beautiful slide because I think as one of the earliest leaders of City of Hope, Samuel Goulter was ahead of his time. He believed that all patients should be treated with dignity and human kindness and recognized that there was more than just treating the disease. This gave rise to the beautiful quote, "There is no profit in curing the body if in the process we destroy the soul." Next slide. So the field of psycho-oncology. Psycho-oncology is a relatively new interdisciplinary field with the aim of addressing psychosocial issues and providing support for patients and loved ones confronting numerous challenges throughout the different stages of the disease. It is composed of dedicated professionals that work with passion from a variety of backgrounds who are trying to address issues faced by patients with cancer, such as psychiatrists, nurses, psychologists, neuropsychologists, social workers, chaplains, and other mental health counselors. It has developed specialized intervention to relieve cancer patients' distress. And we have done that through using psychopharmacology and other specialized psychotherapy, such as cognitive existential therapy, family-focused grief therapy, cognitive behavioral, meaning-centered psychotherapy, dignity therapy, and mindful stress reduction, among others. Next slide, please. So how can we talk about psycho-oncology without speaking about Jimmy Holland? Dr. Jimmy Holland grew up in a small town in North Texas, and as the only child of a cotton farmer and his wife, neither of whom had finished high school, she went on to study and to be one of the few female doctors during that time in the 1950s, and graduated from Baylor Medical College, and later on went on to become a psychiatrist. As the wife of James Holland, a leading oncologist and one of the pioneers of chemotherapy combination, Jimmy was a witness of a medical revolution. While her husband and his colleagues focused on curing people with cancer, Jimmy asked a question that led to the birth of this field. And the question was, how do the patient feel about it? Has anyone asked that question before? Next slide. So Jimmy Holland was born in 1928 and unfortunately passed away at the age of 89 in 2017. She's internationally recognized as a founder of psycho-oncology. So in the 1970s, psycho-oncology came into existence to decrease these psychological symptoms and provide psychosocial assistance to cancer patients, caregivers, and families. As a tireless advocate for supporting the emotional and psychological needs of people with cancer, she had a profound global influence on the fields of psycho-oncology, oncology, supportive care, psychiatry, and psychosomatic medicine. Dr. Holland recognized that people's psychological distress could linger even after they were considered cured of their cancer, and made huge strides to reduce the stigma surrounding the disease. Dr. Holland pushed to recognize patient distress as the sixth vital signs in medicine and played a key role in the development of the distress thermometer. She co-founded IPOS, the International Psycho-Oncology Society, in 1984, and founded the American Psychosocial Oncology Society in 1986. Now, over 60 countries in the world practice the field of psycho-oncology. Next, please. But even before Jimmy Holland was, founding, working in the field of psycho-oncology, we had different countries around the world, but only because these targets focus on Latin America. They were already working with patients with cancer. In Argentina in 1950, the first article was published on the emotional impact of cancer. In Cuba, there were about 60 psychologists in hospitals and cancer clinics working very closely with cancer patients. In Spain, in the 1980s, they started with academic and clinical training, and eventually the first psycho-oncology units in cancer clinics were established by Maria Trill and Francisco Hill. In Mexico in 1980, Dr. Romero Romo was a psychiatrist, and Dr. Beltran Ortega also established a Psycho-Oncology Society in 1987. Brazil in 1980s, they did clinical training. In 1992, the Brazilian Psycho-Oncology Society was established, and there more research in psycho-oncology units. And in Peru in 1980s, INEN first hired a psychologist for neurology and pediatric services, and Maria Liliana Montalbetti was in charge of the psycho-oncology service. Next slide. So as we know, this field of psycho-oncology has been present for many, many years. So now let me talk a little bit about the practice and approach of psycho-oncology with Latinx community. Next slide, please. In the United States, studies have shown that Latino patients show significantly worse depression than non-Hispanic white patients. And they're high risk because of, for many reasons, but especially for English, the limited English proficiency and low income. Latinos are less likely to receive psychological or psychiatric services and intervention. Depression is frequently underdetected and undertreated among ethnic minority cancer patients. Next slide. Starting with City of Hope. In my last 3 years that I've been here, I'm very fortunate that I speak Spanish. I'm from Nicaragua, so a lot of the Spanish-speaking patients come to me. We still have Spanish-speaking patients, being seen by other providers here and using our interpreter services. But I have made a focus on asking for patients to come to me, especially because it's much easier to speak in their own language and also understand more the culture. I have to say that among countries in Latin America, we all have different cultures. It's not that because we speak Spanish is that everybody has the same culture. So I have learned quite a bit. I have learned a lot from them, and it gives me great satisfaction that I can represent my patients here. I also work with SPARC, a cancer support group in California, and Latina Share, which is a cancer support group in New York. And I do this collaboration by either presenting talks about mental health, psycho-oncology, destigmatizing mental health among Latinos, creating videos. That was one of the videos that I created for the Latina Share during COVID, and also I collaborate with this group that is called FIPO that I will tell you a little bit more about it. Next slide, please. So the practice and approach of psycho-oncology with Latin America. Next slide. This collaboration cannot be made without working with IPOS, which is the International Psycho-Oncology Society, which is established in Canada, the American Psychosocial Oncology Society, and other organizations like Nevada Cancer Coalition, the Cancer and Bone Marrow Foundation, the American Consultation Liaison Psychiatry, the American Psychiatry Association, and the American Academy of Hospice and Palliative Care and Palliative Medicine. Next slide. So through people who I'll be talking a little bit more about it, we were able to make great contacts and form extended friendships with other oncologists, psychologists, and psychiatrists that work in Mexico, Peru, Argentina, Spain, Nicaragua, Cuba, Brazil, Puerto Rico, Dominican Republic, Chile, Ecuador, and other countries. In Mexico, we have been working very closely with the National Cancer Institute of Mexico, in Peru with the National Institute of Neoplastic Diseases of Peru. We usually get invited by at every conference that they have. So we are learning so much from their studies that they are doing in these countries. With Spain, and I will walk you through some of the pictures just to bring you through my journey when I visited those countries. Next slide, please. So the history of FIPO started in 2017 when I was still a Memorial Sloan Kettering, and it was started by the founder of my great colleague, who is a psychologist at Psycho-Oncology, Dr. Rosario Costa Muñiz. And from there, the way we started was just accumulating a list of different providers in South America, using the a list from IPOS and APOS. We started reaching out to these providers, and the majority were researchers, and that's how we started, right? So we reached out to Mexico, Peru, and Puerto Rico, and Spain, and then other countries were adding after that. So these are some of the pictures when we were invited at one of the conferences in Peru by INEN, in Incan from Mexico, in Cuba and Nicaragua. During COVID, the time was it was a little bit more difficult to communicate, but we are now back in communication and collaboration. Next slide, please. So what is FIPO? It's an initiative to develop networks, collaborations, and educational opportunities in psychosocial oncology for Latin America. It is an international collaboration founded in 2017, as I said, aiming to connect Spanish-speaking clinicians and researchers interested in psychosocial oncology, supportive care, cancer control, palliative care, and behavioral medicine from Latin America, the US, and Spain. The goal of the network is to develop collaborative research projects and programs, develop and host webinars, disseminate the latest research in psychosocial oncology, and facilitate exchanges and offer information about training opportunities, collaborations, and developments of the field. As you can see, we have a list of many psychologists and psychiatrists that represent different parts of the world. Dr. Costa Muñiz still at MSK. Dr. Galindo, he's a very avid researcher in Mexico. Dr. Montaña in Argentina. We have Dr. Bergerot in Brazil, which he will be presenting after me. And you'll see different people. Dr. Tania Estape in Spain, she's very active in IPOS, and I am here at City of Hope. Next slide, please. So this is a great picture, I think, because it just focuses, with throughout the whole the continent, North America, South America, and Central America, where some of us are located. And it's called Iberoamerica because it's also including Portugal and Spain and Brazil and the rest of Spanish-speaking countries in South America. Next slide, please. So we've been maintaining ongoing collaborations. We have meetings once a month. It's the first Friday of every month. We do regular communication through emails, phone calls using WhatsApp, conferences, co-mentorship of psychologists that are in training. I feel that I have a lot of mentors in this program because they constantly teaching you how to, what's going on in other parts of the world that are affected by cancer. And one of the greatest studies that came out through this wasn't a study, but it was an adaptation of the meaning-centered psychotherapy, which is a psychotherapy that has been used and created for cancer patients. But it's been adapted to different languages. Japanese, in Hebrew, it has been a different adaptation, but we worked on this cultural adaptation of meaning center for Latinos with advanced cancer. Next slide, please. This is one of our trips to Cuba. This was in 2019. We were invited by the the society, the Inter-American Society of Psychology. Rosario, my colleague, and I presented there, and other people were presented from different parts of South America. I presented more on psycho-oncology, and she was presenting the studies of CAMLA, which was the adaptation of the meaning-centered psychotherapy. Next slide, please. This is a visit to my country, Nicaragua. I went in 2017, I believe it was, or 2018. I reached out to a foundation that was called Moby Cancer because I wanted to start collaborating with them. And the Nicaraguan Ministry of Health accepted they invited me. And you can see there in this picture on the left, where I am meeting with one of the oncologists that was in charge of the society, Dr. Guillen, one of the few palliativists that they have in Nicaragua, wearing the red shirt, and I'm bringing all these books from just books of psycho-oncology because those were my gifts that I bought for them. On the top, I am presenting about psycho-oncology to nurses and some of the residents. Also on the right side, it's the only place that they have for radiotherapy in Managua, Nicaragua. I visited there, and as you can see, the picture speaks for themselves. I'm also talking in one of those pictures with the radiotherapist that is in charge of the place. This is a trip that we had in different places in Nicaragua, but we visited the hospital La Mascota, which is the children's hospital in Managua, and I'm there with Dr. Calderon, Patricia Calderon. She looks very young, but she's the pediatric oncologist there. I'm also with one psychologist that covers the entire hospital and a social worker, and then she took me to visit an area that was donated by Japan, where kids come and do play, where they can play while they're getting their chemotherapy treatment. Next slide. This was some of the invitations from the conferences that I was a part of in Mexico, Peru, and again in Peru. Next slide. One of our visits to the National Institute of Neoplastic Disease of Peru. Here, as you can see, the picture in the middle was well presented by oncologists and psychiatrists and also psychologists and social workers and nurses that were also presenting on research that they were doing in Peru. Next slide. And one of my last visits was to Spain. We were invited by the Spanish Association Against Cancer, and with my colleague, Dr. Patricia Parker, who was running the ComSkill lab at MSK, we were able to run a workshop using actors and actresses from Spain and creating, creating situations where we were able to teach, or not teach, but just train how to deliver bad news, dealing with angry patients, transitioning from treatment to palliative care. And then we were able to give, I was able to give one of the classes or presentations that it was recognizing the limitations when communicating news to cancer patients. And this was attended by survivors, cancer survivors, oncologists, and primary cares. Next slide. So what have we learned? What have I learned from this? It's that there's always a reciprocal learning. We bring to other countries what we think we can, what we share, what we know. But there's a lot more learning that we do when we are visiting every country, what they do, with the limitations that they have with treatment and maybe the poverty. We learn so much. I mean, it's just these people are able to treat and provide a quality of care to patients that with so much limitations are able to do that. So we still do cultural adaptation projects. We actually have a bank of all the scales that have been adapted for different countries in Latin America that we use in case we want to do some studies or if we collaborate with anyone else in South America. Next slide. So in summary, what I was hoping to achieve with this talk is to tell you more about the psycho-oncology, what it is, and what it means to us too. It is, as you know, it's a cross-disciplinary and collaborative subspecialty of oncology, focusing on the psychological, behavioral, ethical, and social aspects of cancer in clinical settings. Our role and my role as a mental health provider is to continue to advocate for our community, for our Latinx community, while providing psychoeducation and decreasing the stigma of mental health, and share our knowledge and learn more than anything through collaboration with other centers, countries, and organizations in the US and Latin America. And with the hope to continue the legacy that Jimmy Holland left for us, which was to take care of our cancer patients. This is how far we have gone. This is a journal that we have, Psycho-Oncology, and many books that have been published since then. The one in the middle, Psycho-Oncology, is an 833 pages, I believe. It's a fourth edition, and it's considered our Bible in Psycho-Oncology. And I think this is my last. I acknowledge in memory of Jimmy Holland. She was one of my biggest mentors. And all my psycho-oncologists and oncology colleagues, our supportive care department, and especially to my family and our patients. Thank you.
Thank you, Dr. Rocha, for your wonderful overview of not only the history of psycho-oncology, but also of examples of collaborations with other countries and countries that are so much in need of psycho-oncology services. All right, so then now moving on, I have the honor of introducing our next speaker, Dr. Cristiane Bergerot, who is the head of the Department of Psycho-Oncology at Grupo Oncoclinicas in Brazil. Dr. Bergerot completed a fellowship in the Department of Medical Oncology at City of Hope Comprehensive Cancer Center. She has worked with cancer patients for almost 20 years as a clinician and a researcher. She has authored over 60 peer-reviewed publications, including first author publications in Nature Medicine, Cancer, the British Journal of Urology International, and Psycho-Oncology. She was selected for the prestigious SWOG Young Investigator course and is a past recipient of the Global Oncology Young Investigator Award from the Conquer Cancer Foundation in 2021. She currently serves as the Quality of Life Chair of an ongoing clinical trial, the PROBE trial. She is committed to bettering cancer patients' lives by obtaining a detailed understanding of their quality of life and addressing their quality of life through novel targeted interventions. Thank you, Dr. Bergerot.
Thank you so much, Dr. Salman, and good afternoon, everyone. It's an honor to be presenting here today. Thank you so much for this invitation. And we are going to talk about psycho-oncology and renal cell carcinoma, charting new paths through international collaborations. So this is my personal trajectory since I'm going to base my presentation in this trajectory. So I'm a psychologist from Brazil. I'm also, so I did some training in health psychology and psycho-oncology. My master's and my Ph.D. was in health psychology. And I also did a postdoctoral research fellowship in quality cancer care and another one in genitourinary cancer at City of Hope. And my passion lies in the development and implementations of evidence-based psychosocial program, improvement of quality of life of patients with kidney cancer, and exploration of age-based difference in the cancer experience. So I'm going to showcase my story in 3 chapters. The first one, Psycho-Oncology. So I have 10 plus years of collaboration with Mellas causal kidney cancer. I have 6 plus years of collaborations with Dr. Paul, and geriatric oncology, which I has 5 plus years of collaboration with Dr. Dale. So historically, mental health concerns is not routinely identified and addressed along the continuum of cancer care, even being a common part of the cancer experience. And as we can see in this figure, 38% of patients will report any mood disorders, 32% adjustment disorder, and 25% all types of depressions. So depression and anxiety can appear at many points along the continuum of cancer care, and historically, we've opted to use the term distress since it has less stigma and it's more useful for clinicians. It is also a generic category of emotional suffering, and it's a broad definition that encompasses physical symptoms, practical, social and family and religious concerns. Since 2004, distress has been considered the 6th vital sign in the care of patients with cancer, which emphasizes its importance and the need for regular screening. It is now an international standard of comprehensive cancer care, and this recognition prompts systems of care to develop and implement a comprehensive approach in the care of patients throughout the cancer journey. So Mellas causal has guided me in the development of a comprehensive distress screening program suitable for implementation in Brazil. I had the opportunity to implement the first formal psycho-oncology service in Brazil, and this has resulted in multiple invitations to implement this program in different hospitals across Brazil. So basically, as illustrated in this figure at the bottom of this slide, patients are assessed in the first day of oncology treatment to identify unmet needs and to determine treatment planning. And based on this screening, we classify patients' risk, and for those at mild risk, follow-up and basic support are offered. And for those at moderate to severe risk, interventions, communication with the primary oncology team and referrals are done. So these patients are assessed at pre-scheduled follow-up assessment at various time points of treatment, and also if there's a change in the disease status, And this allows us to monitor patient symptoms and also to treat them promptly. So this program is an integral part of medical care and part of our institutional quality improvement project. This program is also offered at no cost to all our patients. So based on our studies, the ones that I did with Merlos Causal, it's possible to say that this program is feasible, acceptable, and effective in mitigating emotional symptoms and also improving quality of life over time. In our studies, female patients have reported more emotional symptoms than male patients, and patients from poor socioeconomic backgrounds have reported poor quality of life and greater distress. And patients diagnosed with rare cancer reported poor psychosocial outcomes and impaired quality of life compared to the general populations of patients with cancer. In the United States, using the support screening database, our main findings suggest that younger male reported more problems related to distress than female patients. Patients with gynecological cancers represent a high-risk group. Obese patients reported higher levels of problem-related distress than non-obese patients. And these stress levels were strongly correlated with requests for assistance. Age, household, disease stage, lower income, and Spanish speaking were associated with inquiries for psychosocial support. So moving to the second chapter of my story, kidney cancer has represented a big part of it. So Monica and I have been working for more than 6 years, and we have developed a research to obtain a detailed understanding of patient unmet needs and also to address their emotional symptoms and to improve their quality of life through novel target interventions. So our first study was to determine the prevalence of unmet needs among this population. Based on literature review, previous studies have shown a higher prevalence of distress in patients with kidney cancer compared with other types of genitourinary cancers. And in our study, unmet needs were screened using the sport screen, a touchscreen instruments to monitor distress and to timely alert the healthcare team. This is a validate tool to assess different domains of distress. And our findings have highlighted that patients with metastatic renal cell carcinoma reported more problems related to fatigue, finances, pain, how their family are coping with their diagnosis and treatment, sleeping problems, walking, treatment side effects, and transportations. So secondly, we have developed some research to better understand patients' perceptions of their health status and also their prognosis. And to this aim, we firstly developed a study to describe the patient-reported performance status and the provider-reported performance status. And we have noted discrepancy between patients and physicians' characterizations of the ECOG. Basically, patients usually incorporate their social and emotional well-being into their performance status score, in addition to their physical well-being. For the patient's perceptions of their prognosis, we developed a study to understand patients' expectations of cure among a sample of patients with metastatic renal cell carcinoma receiving immunotherapy, and we have noted that a significant proportion of patients harbor inaccurate expectations of cure. And this group of patients also reported higher levels of anxiety. So thirdly, considering the emotional burden associated with this disease, we have started to think about psychosocial interventions that can assist our patients to better cope with their diagnosis and treatment. Previous randomized studies have shown the benefit of interventions to increase mindfulness in multiple types of cancer, including prostate cancer. However, limited data exists in metastatic renal cell carcinoma. So we have evaluated the mindfulness-based cancer survivorship journey, a program within the AM Mindfulness smartphone app, and we have recruited patients at City of Hope and also at my institution here in Brazil. Patients were asked to use this app for 20 to 30 minutes each day for a minimum of 4 days per week over a period of 4 weeks. And notably, symptoms of anxiety and fear of cancer progression have significantly decreased over time, and quality of life have significantly increased over time. No significant differences were identified based on disease characteristics or type of cancer. And moving a little bit forward, we are working now to develop a new measure for assessing health-related quality of life among patients with kidney cancer. We have noted that there is a lack of consensus regarding which measure should be used. So in our first survey study, we have evaluated patients' perceptions about one common measure used in randomized phase 3 trials, the FKSI-19. And for our patients, the most relevant questions were fatigue, lack of energy, and worry that their condition will get worse. And basically 8 of 19 questions were deemed non-relevant at lower level of scrutiny, defined as lower than 50% of patients considering this relevant, including blood in urine, fevers, appetite, bone pain, coughing, nausea, short of breath, and diarrhea. So we are now running our second survey study, and hopefully we'll present it to you in the near future. So Gerion is the third chapter of my story, and there is a growing evidence that support the benefits of geriatric assessment in guiding treatment selections, predicting response and discussion of prognosis. However, little have been done in Latin America, especially in Brazil, since there is a lack of research and well-trained providers. So based on this lack of data, we have decided to first translate and validate the CART2 into Portuguese. These measures usually help physicians to determine the chemotherapy toxicity risk among older patients with cancer. And secondly, we have tested the feasibility and effect of a remote geriatric assessment program in cancer centers located in different states in Brazil. We have known that this program is feasible and acceptable by our patient, and we have also noted an improvement in their functional status, emotional well-being, and quality of life over time. So these studies are results of this continued collaboration that have opened various opportunities in my career. For example, in Psycho-Oncology, I'm currently working in partnership with FIPOL, as Xiomara has mentioned before. This group is the main goal of this group is to enhance training among psychosocial providers from Latin America. I'm also the director of the International Psycho-Oncology Society, and I'm working as an associated editor at the ASCOcancer.net in the psychosocial domain. And in kidney cancer, I have weekly meeting with my mentor, Dr. Paul. I am a past recipient of 2 grants awards for causing on kidney cancer, and we are now working partnership with GU experts from United States, Europe, and Brazil. I'm serving as the quality of life chair of an ongoing SWOG trial and also another 2 other trials. And in Gerion, I have also a weekly meeting with Dr. Dale. I'm a past recipient of the ASCO Global Oncology Young Investigator Award, which has allowed me to test the feasibility and efficacy of the remote geriatric assessment program. I am a member of an expert panel charged with updating the ASCO Gerion guideline, and I'm also part of the MyCAR group, which allows me to work in partnership with other experts. So thank you so much.
Thank you, Dr. Bergerot. Thank you for your presentation that so clearly shows the importance of collaboration between psychology and oncology specialties, that really no good psycho-oncology care can happen without that collaboration. And if it's okay, that could be a good segue to my first question for you. What do you think we need to do, or what do we need to maintain really fruitful collaboration among our specialties?
Yeah, this is an interesting and challenging question. And I would say that first, we should have a clear goal with this collaboration. We also need to be clear about our expectation with this collaboration and trying to maintain regular contact with our mentor, especially when we live in different countries and also when we work in different institutions. We should try to definitely meet the deadlines. Also to listen to other opinions from our team. Usually we work with more than one person in this group. Try to usually provide some feedbacks and to share information. I would also suggest to use a lot the social media. I'm using a lot, and this has really definitely opened a lot of doors in my career, and trying to have some good interpersonal relationship with the whole team. And I think if we can try to maintain a clear conversation and also trying to understand a little bit better what is happening with the group, we'll be able to maintain this fruitful collaboration.
Thank you. In your experience, how do you, or what strategies do you use to translate your knowledge and research results from the developed countries to developing countries?
So I think the first thing I've tried to do is to understand a little bit better about our culture, and especially if we try to implement something in our current institution, trying to understand the culture of this institution. Also try to identify potential challenge that we are going to face in these translations, and some barriers, personal barriers and also resource barriers that we will try to organize everything, trying to make this happen and to be successful. I would also try to determine the best way to motivate our group to work with us, and to try to make this really happy. Oh, not happy, but happen. And try to engage the team, trying to make them feel happy with these new actions. I think engage key professionals and administrations from our institution also help us to translate some of these international standards of care or training programs to our own culture, and also try to create procedures of implementing or of translating something to our own culture. So trying to have some small goals and to progressively increase the complexity of them to, I think even for the group to see that it is possible, and also to be motivated in keeping working on the same directions. I would also suggest to try to review all this process maybe every 3 months or something like that, to see if it's working or not, and trying to fix some errors or to fix some barriers. And also to try to regularly present to your team what is happening, what is going on, so they can also change some feedback with us and try to help us to make it happen, or even to be engaged with our own proposal or our own goal. Thank you.
Thank you. So good relationships and good teamwork are essential, sounds like, for any type of collaboration. We do have another question in the chat that I can go back to, perhaps after I ask Dr. Rocha, going back to Dr. Rocha-Cadman, if we have time. In your opinion and in your experience, Dr. Rocha, what do you think is necessary to improve mental health care in the Latinx community?
Oh, that's a great question, because it's a challenge that we find every time that we meet with our patients that are Latinos. And I find that I spend a lot of time doing a lot of psychoeducation, and not necessarily justifying why they are coming to see us, but also kind of like destigmatizing the need to see a mental health provider. In our culture, when we talk about mental health, we think, oh, I have to be crazy to go see a psychiatrist or a psychologist. But here, what I usually do is, like, I talk a little bit about my interest in dealing with patients that are suffering with cancer in the treatment. And so I find myself at times that I am not justifying, but I'm just normalizing why they are there with us. And so I think we have to do a lot of psychoeducation, use our leaders, Latino leaders, to go and speak to communities, or maybe be more active, so that they feel that they're a little bit more representative. I think that the difference in culture, sometimes coming to speak to somebody that they don't understand their culture, they feel a lot of, not most, but some patients feel intimidated by their clinicians. And I think it all stems from our culture, where we see a physician with a lot of respect, and sometimes we don't ask questions. But in mental health, it's very different, because you add a layer of the stigma of mental health. So I think it's a lot of psychoeducation, asking patients to advocate for themselves, and it's okay, normalizing. It's okay to use a psychiatrist or a psychology. That's what we're here for. Just doing a lot of like reframing too for them. That's how I would approach it. Did I answer your question, Doctor?
Yes, and certainly the stigma of seeking mental health or receiving mental health is not unique to Latinx community, of course, but there are certainly cultural nuances to this that need to be recognized. And also, I think for clinicians like myself who are not from that community to be aware of that, right? And so the education needs to go both ways, so that I know what to perhaps expect or understand why the patient may be reluctant. Absolutely.
Sure. And also, I think it has to start from our clinicians, like, and I think a lot of our oncologists do a great job about saying it's okay to go see a psychiatrist, because it requires a team and an army to help you. So I think that you just keep that in mind, because even as in our own field, we have the stigma of mental health. We have to overcome that before we are able to preach,
Yes. So speaking of clinicians, as your colleague, I happen to know that you are very passionate about clinicians' wellness and well-being and self-care. How do you take care of yourself, or how do you propose that we take care of ourselves working in this field? What's important?
Well, I think I feel that there's two different types of people. The people that get energized by doing what they love most. I tend to fall into that. If I am working in the field that I love and I am very passionate, I just get excited, and I just like I can go on like that. And of course, at some point I might crash, but so that to me, it's like, if I am happy doing what I do, which is psycho-oncology, I feel great. The issue falls when something else at home or with friends become unstable. Like, I think we all take care of our patients when everything is okay. But the moment that we have something going on in our personal lives or vice versa, it makes us not be present. So we always have to, I think we have to be mindful that moment can happen to anyone. And what do we do? Because if we're not mindful that things can go wrong, and that we already work in an environment that depletes us from all the needs from our patients, so even if, as much as we love it, we at times, 3 months, I feel depleted. I have no energy. So, and I'm able to kind of like reconnect and do other things that I feel has worked in the past. One of them, I think, is talking to other colleagues that share similar feelings. Trying to keep things from home, like bringing things home. And sometimes it's very hard to do that. So one of the things that I do is I run. I love running. I'm not a fast runner, but I run. So I do, just thinking that I'm going to run a marathon, I'm going to raise money for cancer. It gives me so much purpose. Raising money for suicide or a hospice, it gives me, it gives meaning to what I do. So I think that's one of the things that I do. And when I'm running, I am in a different space, and I feel that that's my own space. So I feel that being aware of that we could fall into a period of depression or anxiety or feeling demoralized or whatever it is, I think it's a key of like being an advocate to yourself.
Thank you. Keeping the self-awareness, keeping in touch with our own response to the cases that we see and our day-to-day work. Yes.
And I think also, I'm sorry, but I think for clinicians like us, doing collaboration with other researchers, balance that just focusing on patients, right? Because if we only see patients, it gets to a point that it's very tiring. So collaborating and doing research or learning from our research colleagues, I think it's one of the sideways of feeling better and being more present here.
Thank you. I agree. I'll go back to Dr. Bergerot with the question we have from the audience. An amazing presentation. What would you say are the priorities of global psycho-oncology in LMIC? I assume that's a Latinx community.
Yeah, in low and middle income countries. Yeah, so I would say that we should promote some policies that increase access to psychosocial support to our patient, psychosocial treatment, whatever. So yeah, and also to try to improve health literacy among our healthcare providers and among our patients, trying to always to include this domain in the cancer care. And to integrate and to definitely try to integrate the psycho-oncology service into cancer care. And for sure that for this, we will need to improve our training programs for our psychosocial oncologists be more prepared for this, and to have more providers to provide this kind of support, and also to increase the number of research we have nowadays. This will allow us to talk more with our partners and with not partners, but with our colleagues, and try to have more space in the oncology area.
Thank you. Dr. Rocha, did you want to add your opinion on that? What do you think are the priorities of global psycho-oncology in middle income countries?
I think I'm picturing what we have been doing through people. I think it's collaborating, reaching out. We can, when we started with this organization, when Rosario started, I remember coming up with a list of people, names that I will come up to me, and and connecting them and talking about these organization people. And I mean, now it's a big. It's composed by many collaborators. Before we were like 4 people, and I think the more you reach out and the more you're available to these clinicians in different countries, and doing things that we do presentations. Or we used to do presentations pre-COVID in person that we wouldn't charge anything, because we're not there to charge. We're there to bring what we know and learn from what they're doing. And I think it was very humbling to know that they were doing great things that nobody knows, because it's South America. So I think it's bringing awareness, collaborating with them, reaching out to, and trying to make yourself available, so that that relationship continue ongoing. We started with only 4 countries, I think, at one point, and now it's the idea will be that every country in South America is involved, and that among the people that are in every country, we can expand their knowledge and collaboration.
Yes, and I think that the dissemination of awareness and knowledge, particularly among the oncology providers, whether those are physicians or nurses, is kind of at the basis of starting to provide psycho-oncology care, right? Because you can't bring psychiatrists and psychologists to every cancer clinic, but you can make oncologists aware. And we know from our patients how important that is to them, that just being heard by their oncologist, heard how they feel, just being asked, how are you feeling? How are you doing emotionally? Is therapeutic in and of itself. Our patients crave that, they welcome that, they embrace that when that happens from their oncologist. So I don't see psycho-oncology as separate from oncology.
Yeah.
It's across the spectrum, right? So we're lucky to be at the cancer center, but every oncologist, every oncology nurse can bring psycho-oncological care to their practice.
Yeah, it's just learning. Yeah, learning from
exactly.
everyone. And I think when we do it with humility and interest and real, the real interest and passion, you don't go wrong. It's when I think sometimes we make the mistake, or we don't make the mistake, but when we go to other countries representing the United States, there's the sense of like, well, they're like one of the most powerful nations, so and they know it, they do so much more. But it's amazing the work that they do, and that that is known among the Latin countries, but not necessarily from here.
With much less resources.
Yes.
Mm-hmm. Thank you. Thank you so much. There's another comment. Great presentations. Thank you. Thank you for your leadership. Are there any other questions from the audience? How are we doing on time, Miu?
We're good on time. Thank you, Dr. Salman and Dr. Cadman, Rocha-Cadman, and Dr. Bergerot. Appreciate it.
Thank you. Thank you.
Thank
Thank you.
you.
Thank you, Dr. Salman, for being
Thank you.
for helping us.
Thank you
so
very much.
Great
Thank you,
pleasure.
Cristiane.
Thank you, Xiomara. Thank you.